Welcome to Health Signals, the podcast where we help listeners see whether what's happening is a signal or a trend in healthcare and beyond. I'm Alika Lafontaine, a former president of the Canadian Medical Association and top Maclean's Health Innovator. I'm joined by my co-host, Catherine Smart, former president of the Canadian Medical Association and one of Canada's top 100 most powerful women. This week is a special episode where Katharine and I presented together at the North American Conference on Integrated Care, held in Calgary, Alberta. NACIC is a conference organized by the International Foundation for Integrated Care, a leading international body that inspires, influences, and facilitates the adoption of integrated care in policy and practice around the world. Here's some excerpts from that conversation.
I think one of the reasons why so many folks are interested in this discussion is because it feels like healthcare is burning down around us. And I remember coming in as CMA president right after you were finishing your term, and you had a pretty remarkable conversation on power and politics about collapse. And Catherine actually became the first medical leader of a national organization to say the system was in collapse. And you had a variety of reactions to that.
It's true. I did say that, and I didn't really plan to. I just was asked, what do you think, what's happening? There was a lot of people, I think, who were taken aback that I said that, but I think there was also people that sort of went, yeah, that's true. For me, it was very simple. When healthcare isn't getting to the people that need it, and as we heard in the introduction this morning, when our communities and the way we're investing our money and what we're doing for social care isn't making people healthy, and then those sick people can no longer access care, and people are waiting incredible lengths of time, and there's incredible suffering that's happening. That to me is a collapsed healthcare system. And I think this is the opportunity as well that's in front of us right now, is when things burn to the ground, it's an opportunity, I think, to start thinking differently.
No matter where you look, there's a shortage of someone, whether it's an anesthesiologist, a pediatrician, care aides within the hospital, personal support workers in the community, patient navigators, nurses, pharmacists, you could name it, of many different types of people. Everywhere is dealing with shortage right now. That shortage has led to limited or no access. There's 6.5 million unattached patients. They don't actually have a relationship with a primary care physician or nurse or whomever they receive primary care from as a way to stay engaged with the healthcare system when they need it. ERs have been closing across Canada. I know that this is a problem in the UK and elsewhere in the world as well. Things that we just never imagined were possible. We sometimes had the peaks and valleys during flu season where places would be overwhelmed, but it's every day, 130% over capacity or worse. Spread of health deserts. So health deserts are places with little to no health infrastructure. Not only are things collapsing, but programs are actually completely disappearing. And then loss of certain types of programs.
Yeah, absolutely. And again, what we're seeing, public health deterioration. And I think that links back to this idea of why we aren't investing more in communities and community health. And we're not making that link to, if we want a functional healthcare system, we actually need a population that's well and healthy, and we're not really connecting those things. And then, of course, oversight's been challenging. There's been a lot more fragmentation of things. We're between sometimes micromanagement, no management, lack of planning, lack of accountability, lack of data, and other places that are over-rotating on that to the point that the bureaucracy is a barrier to innovation. So all these things, I think, came together to land us where we found ourselves during our presidency.
Yeah, I think that this is the inevitable destination of collapse. We moved from an area where we had stability, where we planned, where every single day is a crisis. Right. And when you're dealing with crisis versus growing in stabilized programs where you know that the next day is going to have some sort of repeatable pattern, folks are starting to just off the cuff suggest changes because we really are in that bad of a situation.
Yeah. And I think when you get to the root cause of kind of what led us here, it's this doubling down on the status quo. And we were talking that inevitably with the status quo in any situation, there's entrenched interests it serves. And then it's all the people that it doesn't serve. One example I often think about, there's been a lot in the news about nursing agencies and the cost of driving up nursing and how this is costing all this money. And this is horrible, which obviously that's a problem. But to me, the real question that we should be asking is, why do nurses want to work in those agencies? What need is being met there that's not being met in our status quo system? There's something that draws people there. And I think so often we're not taking these opportunities of looking at what's not working, what's collapsing, to really ask the question, what about the status quo isn't working?
Both Katharine and I, we work in rural communities. When Medicare first came in, publicly funded healthcare services, the approach that was taken was that people would go down the street for their care and not go anywhere else. It was not envisioned that people would be transported thousands of kilometers away for subspecialized care. We never imagined that healthcare providers would migrate from place to place, that people would normally shift. Half their time they'd spend in Alberta, half their time they'd spend in the Yukon or somewhere else. And our systems are fit for purpose for a world that's still in the past. And today, our systems are hyper fragmented because we insist on continuing to use systems and approaches that are just aged out. They just don't work for the way that people utilize systems with hypermobility. And they don't deal with folks who do want to work at multiple locations and be hypermobile themselves.
Absolutely. I think what we wanted to ask the audience is, please go on to Menti again. You can go online or you can scan that QR code. I think we both feel strongly that this sort of insistence, this doubling down, I guess you could say, on the status quo, the lack of recognition that healthcare is being disrupted, and this need to mind shift from a sickness, illness-based care is a big part of why our healthcare system is where it is. We'd love to hear from all of you what you guys think around what's the biggest risk. What I find so interesting about being with a group like this is you're asking those questions like we heard this morning about why are we where we are and what does different look like, rather than how do we keep trying to recreate the same thing?
What I find interesting about this Menti is just how many different things have come up. If you look at the responses, inequity, burnout, collapse are still high up there, but everything else is even. And I think that this reflects a system that's caught in the midst of collapse as well. There's so many problems. Where do you start? What do you prioritize first? What is going to have the biggest effect?
Yeah.
And I think that's part of why this conversation is so important. There's been the talk about the creation of a health economy over yesterday and today. And there's two things that I think about when thinking about that stream of thought. The first is that economies are often trapped in constructs, right? So what do we think of economic growth? That's a capitalist mindset where growth is supposed to be unlimited. And the thing that's implied with that type of model is that you're able to bring up the least of people because of growth. It's not because of design. It's because it continues to get bigger and bigger. I think that's actually the antithesis of what we're talking about with community-enabled health. What we're talking about is local systems that are having to grow, that aren't necessarily supposed to grow to unlimited sizes, but are supposed to grow to be fit for purpose. They're systems that are supposed to be big enough to solve the problem, but not bigger than they're supposed to take up.
Collaboration, trust, funding, those things all go together, don't they? We'll make a rule so you can't do that. We'll make a rule so you can't do that. We'll make it so that can't be funded. And there's not a lot of generative conversation about what are we doing to enable actual change and evolution of the healthcare system, rather than just whack-a-mole the pieces we don't like. And I think, when we're talking about trying to move to community, there has to be that trust and that collaboration, that willingness to shift some of that funding and that power, because we all know funding and money is ultimately power. And I love the saying, your budget is your priority. If we want to be serious about shifting in the community, allowing those relationships like you discussed, because I agree, the most meaningful parts have been relationships.
Yeah, and it's really about creating that shared mental model. Why does a patient wait 12 hours to see someone in emergency? It's because they believe at the end of 12 hours, someone will be able to help them with their problem. If they didn't think that, they wouldn't wait 12 hours. Why does that patient wait in the hallway with no privacy and sometimes no dignity in order to receive the care? It's because their problem is so big that they feel like if they don't do that, they won't be able to have their problem solved. Why does a provider, put in 70 plus hours per week? I have colleagues who manage, patient panels of 5,000 as family physicians in communities where they're on call every single day. They get called on vacation. They get called at their kid's musical. They get called for all these other things. It's because they know how important they are in making sure that people get the care that they need. And they believe that if someone does ask them for help, they'll be able to help them out do those things. We've often talked as presidents of the CMA how healthcare system has really lost the plot. Like we've gotten so caught up in saving money that we've forgotten how to produce wellness and health. We've gotten so into using technology to sometimes invade every aspect of people's lives and professionalize the oversight of that data that we've forgotten that what we're actually depending on is the person who lives down the street to get up and check on the person who's lonely. I always find it ironic with virtual ICUs and ERs. At the end of the day, you're actually just asking whoever's living with the person to go solve the problem. And I think that in the broader scheme, we have to move beyond this idea that everything is the same. And I think this is a dangerous part of collapse as well. And I think community-enabled care will be the conversation that will get us to the other side. Everyone's not the same. The physician is not the same as a nurse versus the same as a pharmacist, but we all can do the same things. But we have to articulate what those things are and then figure out who has capacity to do those things. Instead of getting so caught up in these titles, what are the solutions that can solve those problems, which requires professionals and experts within the system to be honest and transparent about where that value needs to come from. And then how can we have those two things meet, which I think is the role of politicians. That's the role of conferences like this. And I think that then takes us to the opportunity.
Yeah, absolutely. And like we started with, and that's why we wanted to take you guys through the arc of our experience being embedded in the healthcare system from the national level over the last few years. And I think sometimes it can be overwhelming and we can all get stuck in sort of the negativity of where we find ourselves. But I think when we flip that frame, we have this almost like religious belief about our healthcare system or this like unusual attachment to it. We've really struggled to admit that the design or the lack of design really is what it is, doesn't really work. And I think it probably needed to come to this point of collapse for us to be willing to build the trust and think differently. And we need citizens, I think, to get rallied up enough around the state of collapse to say, what I actually want to deserve is an integrated system, and let's do the work to get there. I think by recognizing the status quo and our sort of almost addiction, mental addiction or belief in it is what's created a lot of these problems. By rejecting that and being open to actually rethinking about what we're actually trying to do and realize we actually are trying to create wellness and well-being as opposed to a focus only on health and sick care, we have that opportunity to create flourishing communities and a flourishing population. Because you're never going to, health or sick care your way towards a well population. And then again, I think what we realize is we've got to recenter from institutions to community. And that's where I think those practical pieces like funding, investments, where are those pieces going? We've got to be flipping that around, right? We're spending the vast majority of our healthcare dollars on the last weeks of people's lives in an ICU. What value are we creating for that family or that person in that setting? And what value are we creating for our country? So I think we need to be thinking differently about some of these things. And I think by taking these things, there is really an opportunity. And I think those conversations are what's happening here. What is your sort of dream when you think about optimal health and social care? And again, I think we're seeing a lot of these ideas, right? Equity, accessible, integrated, seamless, inclusive, available, prevention, connected. Everyone should flourish, truly patient-centered, like actually walking the talk, not just saying the words. So I think we share that dream. And I think we know that if we want an illness system that's there to serve people when they need it, because obviously that is important. We need people and communities that are healthy and thriving, and we need that design to make sense.
I'll just leave with one final thought before turning it over. We talk constantly about innovation in healthcare, and creativity obviously unleashes innovation. One of the things we forget about creativity is it flourishes with constraints. We have to have rules around what we're trying to be creative about. And there are no rules right now in Canadian healthcare to a great degree. When you look at the way that people are regulating, that's really the minister deciding whatever they want to do, no matter what province or territory. When you look at the spending of healthcare dollars, don't even have to be spent on healthcare. They just go into general budgets. We talk about growing proportions of budgets within healthcare. No province or territory has ever said we will spend at least this much. We don't give specific advice on people who are like, this is how hard we want you to work. This is how unreasonable. You've been in situations where, and you told me these stories, where you've been on call continuously for days at a time, and you feel like you can barely continue moving on. I've been in situations in the OR where folks have come in and they've had very bad outcomes, either disability or death, you just move on to the next case. You don't even sit and mourn. These types of situations are unreasonable, but we don't create constraints about what we actually want to build.
I'd like to thank all of you for listening. What I'm really optimistic about is being in a room of people like all of you who are doing that thinking, who are asking great questions. And there's so many great examples, I think, that we've already heard at this conference of places that are really starting to do things differently with this lens and creating smaller systems within the broader system that are actually working and serving patients. So I think you guys are the think tank for the future.